The title of my talk is Understanding Genetic Counseling Through a Case Study. So I'm really going to be talking about just the basics of what genetic counseling is, what do I do, and I'm going to be talking about a case study that sort of demonstrates the importance of genetic counseling. First off, I don't have anything to disclose. As far as learning objectives, as I mentioned, I'm going to be talking about what genetic counseling is, what does a genetic counselor do, and then some of the core values of genetic counseling that are important to me and the profession, and then really demonstrating the importance of genetic counseling through that case study. So I'll start by talking about just genetic counseling, just in general, and kind of giving you a 101, so to speak, about the profession. So I want to start with just kind of a few of these scenarios that you see on your screen here. And so these are a few scenarios where genetic counseling may be an important consideration. I'll let you guys kind of read that by yourself. I'm not going to kind of read them over, but for me personally, these are the kind of scenarios that when I was, thinking about going into genetic counseling, the idea that someone could be, uniquely trained to talk to families about genetic conditions and the implications for family members and such was what drew me to the profession in the first place. So I'm going to give you a couple seconds for that. And then, so the next thing I want to talk about is, what a genetic counselor is not. I think there are a lot of misunderstandings and misconceptions about genetic counseling in the world. So first off, I can tell you that, one of the main things that I have to deal with just with the lay person, I often have to tell them, no, I do not work in cloning. That's not a thing. And also I do not deal anything with designer or test tube babies. So that's also not a thing. But I think the more common misconception, especially in the world of healthcare, for genetic counseling, is that somehow genetic counselors are doctors or physicians, and that we diagnose or treat people, which we definitely do not. So moving on, let's actually talk about what does a genetic counselor actually do, right? So in general, I think genetic counselors are part of playing a role in the process of diagnosing a genetic condition. So for us, it's more about the steps leading up to deciding about a particular genetic test or what happens once a diagnosis is made and, we either get a result that's positive or in a lot of cases, we get an inconclusive result, especially when you're doing broad genetic testing. So I think generally speaking, genetic counselors, I like to think of it as having advanced training in medical genetics and counseling to guide and support patients seeking more information about how inherited diseases and conditions might affect them or their families, and to interpret genetic test results based on your personal and family history. And then the other thing is that they work in a lot of different specialty areas. So I myself work with, as Dr. Brock mentioned, I work with him in neurogenetics, but there are plenty of subspecialties like pediatrics, adult cancer, prenatal. So, we're found in a lot of different clinics and a lot of different areas. I also want to point out that, on any given day, a genetic counselor actually is playing multiple roles. I mean, I'm not just doing one thing at a time. So, there are days that I'm playing more of a teacher and I'm trying to educate families or even providers sometimes. There are days that I'm focusing more on, counseling a family that's just gotten a really tough result. And then there are other days where I'm just kind of almost a glorified, medical secretary where I, putting in a lot of orders. I'm dealing with a lot of calls. I'm trying to clean up any, sort of confusions or messes. So really there's a lot that, a genetic counselor can do. And then the other thing is that genetic counselors can actually work in a lot of different areas. So, traditionally, I think we've worked in universities and hospitals, but increasingly you can find us in laboratories, nonprofits or government, And then also, I think more recently, we are being seen in marketing, startups. So really, there's a lot of opportunity there. This slide, I want to talk a little bit about the genetic counseling process itself. So, we talked about what genetic counselors are, but there's a slight difference that, genetic counseling, the process is not necessarily only provided by genetic counselors. So certainly genetic counselors are uniquely trained to do that. But I have personally, have seen physicians, nurse practitioners, and other providers, even pediatricians, may be providing some amount or some degree of genetic counseling at any given time. If you think about ordering any kind of genetic test, even just the fact that you have to tell someone that it was negative, that is a form of genetic counseling, depending on, how you put that into context. So really, there is the process of genetic counseling, and then there's, what genetic counselors are trained to do. So as far as I myself, when I have a formal genetic counseling visit with a particular patient and their family, there are really 5 main components. So, there's the information gathering. A big portion of that would involve the family history and the pedigree. And then establishing or verifying a diagnosis, either through testing or some other way. And then risk assessment. And, that could be based on the previous information gathering or the test results. Information giving, that's a big one, especially I think in neurogenetics. There's a lot of education and information giving. And then lastly, psychosocial counseling and support. And so this is where the counseling kind of comes in our title, where, we can really hopefully talk to families and their kids about, adapting to genetic contributions to disease. And that does involve, emotional, social, cultural, other sort of parts of the interaction. And then the other thing that I want to talk about is our sort of core values of genetic counseling, or our philosophy. So I've listed some of the really major ones that I tend to think about at any given visit. The ones that I want to point out specifically are the complete disclosure of information. So I think that's a little bit sort of misleading, or rather what I mean by that is I kind of have adapted that to say complete disclosure that is relevant to my to a patient's decision making. So I don't want to necessarily be providing information if it's not helpful or if it's overwhelming to the family. You can do more harm that way. So that's especially the case when you're doing broad genetic testing, like, Dr. Brock's talk mentioned about exome and genome, where you have to get an informed consent, and there's, implications for other family members. There's implications for insurance. There's implications for other potentially risk for other diseases. And so all of that, you want to be thinking about what is sort of important to the patient, what is important to their family. And then the other one I like to point out is the non-directive counseling. So this, I think, is a more traditional value that I have adapted over time. So I think it's not so much non-directive, which is to say I don't offer anything to the patient. I think for me, it's more non-prescriptive. So what I mean by that is, I'm never going to coax or, obviously force someone into choosing a test or something that, they're not comfortable with. But these families are presumably coming to see me for my knowledge and my expertise and my experience. So I think it would be, a shame if I didn't actually share my opinion, using my clinical judgment. So I think, for me, it's really it's a two-way street between myself and the family to talk about what is important to them and, what are the things that they would want to know, while also sharing my expertise. So let's talk about now a particular case study. And I think this case that I'm going to be talking about is a really demonstrates sort of the complicated depths of how genetics can impact a patient and their family, and why genetic counseling can be helpful. So the background for this patient is, this was a 9-month-old proband or 9-month-old male who was referred to child neurology for hypotonia. And then on further chart review, apparently mom was a carrier for Duchenne muscular dystrophy. So, and by this point, we knew that the pediatrician had actually ordered targeted DMD deletion duplication analysis, and that the proband had reportedly tested positive for a likely pathogenic duplication in the DMD gene. And I've actually highlighted what that variant is, and I will come back to talk about it in just a second. Just as a brief sort of overview of what DMD is and what it's associated with, I'm sure most of you are aware, but there are a group of conditions called dystrophinopathies. They're a group of X-linked neuromuscular conditions, and they include sort of at the very severe end of the spectrum, Duchenne muscular dystrophy, which usually presents in early childhood, is characterized by significantly delayed motor milestones and proximal weakness that is progressive over time. And then on the sort of more attenuated side of things, you have Becker muscular dystrophy, which is a little bit of later onset weakness. And then you could also simultaneously have dilated cardiomyopathy in these individuals as well. As far as biochemical findings are concerned, with these conditions, you will see significantly elevated creatine kinase levels, which are a mark of the breakdown of the muscles in the body. So in terms of the genetics of the DMD gene, the DMD gene codes for a protein called dystrophin, which is important for anchoring and strengthening muscle fibers. I already mentioned that the DMD gene is inherited in X-linked manner. So what that means is males with a pathogenic variant will be affected most likely. And then females with a pathogenic variant may or may not be affected, depending on a bunch of other factors that are a little bit beyond the scope of this talk. But one of the things that we do in our clinic when we see kids with possible Duchenne muscular dystrophy, we actually look at something called the reading frame of the DMD gene. So what you can see that to the right here, where where you can see 79 exons of the DMD gene, and exons are just like the coding portions of any gene. And for the DMD gene, it's pretty large. It's actually the biggest gene in the human body. It contains 79 exons, and I like to think of it as puzzle pieces being fit together, or even Lego pieces. The idea is that if you have a mutation or a variant that basically still allows for pieces to kind of match up and come together, that would be referred to as an in-frame variant, and typically those are on the milder end of the spectrum. On the other hand, you can have out-of-frame variants where the reading frame is not able to sort of recover or match up the pieces because of that variant, and those tend to be on the more severe end of things. There are obviously exceptions to this rule, but this is, it's a good rule of thumb for us in clinic. So let's come back to, our case. So this was the patient's first visit with the MDA clinic, which I think Dr. Lakota and Dr. Rogers already covered actually. And so we found out that mom had a specific carrier screen during pregnancy, which tested for SMA, cystic fibrosis, Fragile X, and DMD. And she was apparently positive, quote unquote, for a likely pathogenic duplication in DMD, which you can see to the right. Now, at this point, I did not have a formal visit with this family, but Dr. Lakota, who was actually seeing this patient, asked me to consult on this patient just sort of just temporarily because of the variant that was found and the uncertainty for it. And the reason I say that is, so when we looked at the proband, he had no significant motor delays. He had no other developmental delays either. His development was pretty normal. There was no family history of muscular dystrophy. And his exam was totally normal, except for some mild hypotonia, which was not concerning to the physician in this case. So, it kind of left us with, well, is this variant really truly pathogenic or not? So, to get a little bit further into this DMD variant, which is what I did at the time. So I mentioned it's this duplication of exons 1 to 2, which I've actually highlighted in the picture to the right. So you can see it's at the very beginning of the gene. But what's really interesting is that the effect on the reading frame could not be predicted. So we don't actually know if this variant is in frame or out of frame, so to speak. A similar variant had been reported at least once in a paper from Norway, but there wasn't much detail given, except for the fact that there was a boy that with a similar variant that had a diagnosis of Duchenne muscular dystrophy. And so this particular lab that did the targeted testing for the proband classified it as likely pathogenic. But as I had already said, given that, our proband in clinic seemed to be doing okay, he did not have any signs of weakness. His development was normal so far. We decided to do some further workup. So here was our plan. So we decided to check his CK levels, which, as I mentioned, should be elevated if someone has a dystrophinopathy. We also wanted to order a microarray, a chromosomal microarray. The reason for that is because the duplication involved the first two, exons of the DMD gene. We actually don't know if this duplication involves other genes in the neighboring vicinity, in which case the patient may actually be at risk for something else potentially. So that's something we wanted to order. We also wanted to order a neuromuscular panel through a different lab so that we could take another pass at the DMD variant. And not many people know this outside of the genetics world, but not every lab actually classifies the same variant in the exact same manner. So there's not, there is a standardized method, but there are differences between labs. And so that's what we'll see kind of in a bit for this particular case. So this is what we came back for the genetic testing for the proband. So on the left are the results for the microarray. And as you can see, this is what happens when you do a microarray, which in and of itself is a broad form of testing. So the proband was found to have 2 variants of uncertain significance, meaning, we don't know if these are truly disease causing or not. All of us have normal variation that, that's half of my job is just discussing normal variation that does not necessarily correlate to disease. So, the proband was found to have a 12q duplication, which is new and obviously something that needs to be discussed. And then as far as the other duplication, he was found to have an XP duplication, which involves the DMD gene. So now, this is giving us a little bit more information about that particular variant. So we're going to come back to that in a second. And then as far as the panel is concerned, now we have a couple of different things to talk about. So he was found to be a carrier for Wilson disease. So that's one thing. And then the second thing is, that DMD variant that we have to sort of address because that was the purpose for doing this testing to begin with. And then there seems to be another variant that was also found in a different gene that also needs to be addressed. So again, the point of this is that when you do panel testing and chromosomal microarray, you are you're casting a wide net. And so there are lots of things that can come back. Carrier status, uncertain variants, and all of that does require, counseling for the family. So I, at this point, saw the patient, in a follow-up visit, and I did a formal genetic counseling visit. His development was normal. He was continuing to make appropriate gains, especially in the motor areas. His CK levels were totally normal. So no clinical indication of a dystrophinopathy. I did a family history. There were no neuromuscular concerns, right? So now this really becomes like a counseling visit. So for the microarray, we had to discuss this 12q24 duplication. Luckily, this region does not involve any disease-associated genes, at least as of our current understanding. And so I was able to be reassuring that this was just likely normal variation. And then as far as the XP21 duplication, what's interesting is this lab actually classified it as uncertain significance. So this is basically the same DMD variant, which involved exons 1 and 2, is now being classified by a different lab as an uncertain significance. And they're basing that on conflicting reports of pathogenicity, which does actually seem to fit more with what we know about our patient, given that, his development is normal. He doesn't seem to have signs of any weakness. And his CK levels are totally normal. So then I had to talk about the panel. So obviously I had to discuss this carrier status for Wilson disease. So meaning he does not have this condition. It does not give him any sort of symptoms, but for the future, there may be family planning implications, right? So that's one thing. Obviously talked about the DMD variant. The panel didn't give us any more information than the CMA did. It was sort of the same thing, but just kind of looking at it in a different way, which is often what ends up happening when you do a panel and a microarray. And then the last variant that was found, luckily, was in a recessive gene. And so I was not concerned about that at all because he only had one variant. And so, at most he could be a carrier, but again, likely this is just normal variation. I could be reassuring. So the sort of the next step for that is, after discussing the carrier status for Wilson disease, the parents actually in this case were young and they were interested in expanding their family. So now they are expressing interest in carrier testing for it because they want to know, do they have a risk to have a child with Wilson disease, right? So that was sort of the next thing that happened. So what ends up happening is we end up doing carrier testing for dad, which he was negative. But then mom was actually found to have 2 different pathogenic or disease causing variants in the ATP7B gene, which is associated with Wilson disease. So now we are having to deal with the possible diagnosis of a completely different condition in the mother of the child that we originally saw. So this is going to show you what that test report looks like. As you can see, it says the result is positive and that there are 2 pathogenic variants listed. One of them, the one that was identified in her son, but then a completely different one. And what I want to point out here that not many people notice is if you look at the small print for this particular lab, their family testing actually involves full gene sequencing and deletion duplication analysis. So what that means is they're not actually looking for just the variant that was found in the original proband. They are taking a full pass through the ATP7B gene, or any gene for that matter, if you're doing this type of testing. So obviously the chances of this happening are, astronomical, but it is a possibility. And it's because in this case, the lab does actually check the entire gene for other variants. So let's take a quick foray into what Wilson disease is. So it's a disorder of copper metabolism. There's a wide range of onsets. So you can have childhood onset of features, and you can have late adult onset features as well. Typically, there's a trio of findings. So you can have liver or hepatic findings, you can have neurologic findings, and then you can have psychiatric findings, or any combination of the 3. There are some lab findings as well. So biochemically, you would see low serum copper and ceruloplasmin, and you would also see increased urinary copper excretion. This is one of those conditions where there is actually treatment in the form of copper chelating agents that can sort of reduce the burden of copper accumulating in the body. So the ATP7B gene codes for a copper transporter that actually transports copper from the liver to the rest of the body. And it's inherited in an autosomal recessive fashion. So what that means is someone who has Wilson disease has biallelic pathogenic variants on both copies of their ATP7B gene. So coming back now, we are having to see mom, right? So we are putting proband aside for now, and we're seeing mom. So mom is a 30-year-old female, seemingly having a molecular diagnosis of Wilson disease. And what's important to note here is it is actually truly consistent with the diagnosis because of the previous family studies we did. We know that mom has 2 variants, and we know that they are on both copies of the ATP7B gene because of the studies we had done in her son, who only had 1, and her husband, or the son's father, who was negative for any variants. And so that's how we know that both variants are on opposite copies of the ATP7B gene. So this is actually consistent with the diagnosis. On first pass, she seemed to be asymptomatic, but on further review and talking to her, she had hepatosplenomegaly, which is a sign, which can be a feature of Wilson disease. She also had long-standing anxiety and depression. She had slightly elevated LFTs, and luckily, she did not seem to have any sort of neuro or neuro features that can go along with this, like dystonia or chorea or abnormal movements. And so when I did a family history for her, so now I'm doing a family history specifically for the mom, I find out she has an older brother who is healthy, presumably. She has an older sister who also has longstanding anxiety, depression, and elevated LFTs. So again, potentially something to think about for her relatives, but also things that are extremely common in the population. So definitely something to discuss. We assume that mom's parents are obligate heterozygotes or carriers. The reason for that is mom has two variants. So we know that one variant had to come from mom, and her mom, one variant had to come from her dad. And then when we did follow-up biochemical testing, we were able to confirm the diagnosis based on her findings, which included the low copper and ceruloplasmin and the elevated urinary copper. So we were able to confirm the diagnosis. At that point, because we, myself, I see mostly children. So, and I'm not, we don't deal with Wilson disease specifically. So we referred her to a specialist at the U of L neurology clinic. And then as far as reproductive counseling, because remember, the original purpose for doing testing to begin with was to find out if the parents had any increased chance to have a child with Wilson disease. So I was able to tell the mom that all of her children would be carriers for Wilson disease. However, she did not have an increased risk to have a child with Wilson disease with her current partner. So that is her son's father. Because we had tested him, we know that he does not have any variants. The two of them together would not have an increased risk to have a child with Wilson disease. So in terms of follow-up, now remember we talked about there's a brother and there's a sister for the mother that it was just diagnosed. So it turned out that brother had declined testing. So, the option was offered because, again, with Wilson disease, the age of onset is so variable. Even though they are, in their adulthood and their 30s and presumably, reasonably healthy, there still is a 25% risk potentially to have Wilson disease. And there's certainly a 50% chance to be a carrier. So the option was offered to both relatives. The brother declined testing. So obviously he still has a 50% chance to be at least a carrier. The sister did consent to testing. And so I was able to order testing for her. Fortunately, she was negative for both variants, and I was able to counsel that her children are not at increased risk for Wilson's disease. So coming back, so I think actually going back to this, I think this case really sort of started out with one thing, and then you can see how it kind of, ended up in something completely different, something completely unexpected. So I think this is where this is why I brought up this case, because I think it really demonstrates how genetics can be tricky, and then genetic testing itself can be very complicated. There are a lot of implications, and it may not be limited to the proband. It may actually, have implications for other generations, potentially multiple generations. So if we come back to the original case, which, again, was that proband that had supposedly the likely pathogenic DMD variant. So at this point, we are continuing to follow him. He is doing well. He's scheduled to see us, I think, in actually January, but so far, no signs of a dystrophinopathy. And on further research, what I was able to find, and I've shown a table there, is that there does seem to be now emerging data about incidental DMD findings, or these so-called mild or benign variants. So for example, I've highlighted one particular one where it seems to be a very similar duplication of exons 1 and 2 found in the father of a female fetus with a DMD variant. So a healthy father found to incidentally have this exon 1 and 2 duplication. So obviously this is something that, I'm going to share with the family when we do see them for follow-up. And, obviously this is something we have to monitor over time, because clearly we are just learning about the spectrum of variants that can be found in DMD, and they're not necessarily all pathogenic or disease causing. As far as where mom ended up, she does have a diagnosis of Wilson disease. She is plugged into, U of L neurology. Luckily, she has a purely liver phenotype at this point. So no, significant neurologic or psychiatric features aside from that anxiety and depression. She has started a low copper diet and a copper chelating agent. So she is doing well. I put this picture of this handwritten note that she actually left for me in clinic. And I really do treasure it. This case, I think, was quite honestly shocking and upsetting to many of us in our clinic. We started out with a 9-month-old baby and ended up with diagnosing a completely different condition in mom. So I don't think any of us could have predicted that. The chances are astronomical. But I think the note reminds me that, in this case, the mom was thankful that we had diagnosed her, that, she was able to get treatment, because if we hadn't have done that original panel on the program to begin with, we would have never found out that mom had this diagnosis. So I think, again, ultimately, this case is a really good example of how genetics is unpredictable, how there's a lot of complicated factors going into genetic testing. And this is why, genetic counselors can play an important role in healthcare and can sort of help navigate all the tricky sort of things that can come up. So that's all I have. These are my references, and I guess any questions?